Welcome to Pediatric Case Review. Today we will be discussing eczema herpeticum in pediatric patients, a potentially serious condition that requires prompt recognition and treatment. This lecture will provide you with practical approaches to identify, diagnose, and manage this condition in your clinical practice. Let's begin with a fundamental question. Which of the following best defines eczema herpeticum? Is it a bacterial superinfection of atopic dermatitis, a disseminated herpes simplex virus infection in patients with pre-existing dermatosis, an allergic reaction to topical steroids in eczema patients, or an autoimmune response triggered by severe atopic dermatitis? The correct answer is B. Eczema herpeticum is a disseminated herpes simplex virus infection that occurs in patients with pre-existing skin conditions, particularly atopic dermatitis. It is also known as Kaposi varicella-form eruption and represents a dermatological emergency in pediatric patients. While it most commonly affects children with atopic dermatitis, it can also occur in other skin conditions that compromise the skin barrier function. A 3-year-old boy with a history of atopic dermatitis presents with sudden onset of painful, punched-out erosions and vesicles. His mother reports he developed fever and irritability 2 days ago. Which clinical feature is most characteristic of eczema herpeticum? Is it scattered petechial rash on extremities, clustered vesicles that evolve into punched-out erosions, large bully formation on flexural surfaces, or scaling plaques with central clearing? The correct answer is B. The hallmark of eczema herpeticum is clustered vesicles that rapidly evolve into punched-out erosions. These lesions typically appear in crops and are monomorphic, meaning they are all at the same stage of development. The vesicles often umbilicate before rupturing to form painful erosions. This presentation, especially when accompanied by fever and irritability in a child with atopic dermatitis, should immediately raise suspicion for eczema herpeticum. Where do lesions of eczema herpeticum most commonly appear initially? Are they primarily on sun-exposed areas, areas of pre-existing dermatitis, exclusively on mucous membranes, or palms and soles? The correct answer is B. Lesions of eczema herpeticum typically begin in areas of pre-existing dermatitis, particularly in regions affected by atopic dermatitis. This is because the compromised skin barrier in these areas facilitates viral entry. The eruption most commonly affects the face, neck, and upper trunk, but can spread rapidly to involve normal-appearing skin. The distribution pattern often follows the distribution of the underlying dermatosis. A 5-year-old girl with known eczema presents with widespread vesicular eruption for 3 days. Which systemic feature suggests a diagnosis of eczema herpeticum rather than an eczema flare? Is it mild pruritus, high fever and lymphadenopathy, chronic fatigue, or seasonal allergies? The correct answer is B. High fever and lymphadenopathy are characteristic systemic features of eczema herpeticum that help distinguish it from a typical eczema flare. Children with eczema herpeticum often appear systemically unwell with fever, irritability, and significant malaise. Regional lymphadenopathy is common. In severe cases, patients can develop viremia with systemic involvement of internal organs, making prompt recognition and treatment essential. On physical examination, which finding is most specific for eczema herpeticum? Is it ill-defined erythematous patches with scaling, grouped vesicles with umbilication and punched-out erosions, weeping, crusted plaques with fissures, or hyperpigmented macules and lichenification? The correct answer is B. Grouped vesicles with umbilication and punched-out erosions are the most specific examination findings in eczema herpeticum. These monomorphic vesicles are typically 2 to 3 millimeters in size and appear in clusters. Their uniform, punched-out appearance after rupturing is distinctly different from the polymorphic nature of typical eczema lesions. This characteristic appearance is key to clinical diagnosis. A 2-year-old with severe atopic dermatitis presents with multiple vesicular lesions on face and neck, fever, and lethargy. Which examination finding indicates a potential complication requiring immediate attention? Is it mild xerosis on extremities, ocular involvement with conjunctivitis or keratitis, post-inflammatory hyperpigmentation, or flexural lichenification? The correct answer is B. Ocular involvement manifesting as conjunctivitis or keratitis represents a serious complication of eczema herpeticum that requires immediate attention. Herpes simplex virus keratitis is an ophthalmologic emergency that can lead to corneal scarring and permanent vision loss if not promptly treated. Any child with eczema herpeticum involving the periorbital region should receive urgent ophthalmologic evaluation, even if they do not have obvious eye symptoms. Which diagnostic test is most appropriate for confirming eczema herpeticum in a pediatric patient? Is it skin biopsy with histopathology, PCR testing of vesicular fluid, serum immunoglobulin E levels, or patch testing? The correct answer is B. Polymerase chain reaction testing of vesicular fluid is the most appropriate diagnostic test for confirming eczema herpeticum. PCR offers high sensitivity and specificity for detecting herpes simplex virus DNA and provides rapid results that can guide timely treatment. While viral culture is another option, it takes longer to obtain results. Zinc smear can be performed quickly but has lower sensitivity and specificity compared to PCR. An 18-month-old with suspected eczema herpeticum arrives in the emergency department with extensive vesicular eruption and fever of 39.5 degrees Celsius. Which laboratory investigation is most important in the initial workup? Is it complete blood count with differential, liver function tests, herpes simplex virus antibody titers, or patch testing for allergens? The correct answer is A. A complete blood count with differential is the most important laboratory investigation in the initial workup of a febrile child with suspected eczema herpeticum. It may show leukocytosis with a left shift, suggesting a systemic inflammatory response. This test helps assess disease severity and can provide clues to possible bacterial superinfection, which is a common complication. While viral testing is crucial for diagnosis, basic laboratory studies are essential for evaluating the child's overall status. Which combination of findings is most consistent with the diagnosis of eczema herpeticum? Is it chronic, pruritic rash with lichenification and elevated immunoglobulin E, acute monomorphic vesicles, punched-out erosions, and positive herpes simplex virus PCR, erythematous plaques with silvery scale and family history of psoriasis, or erythematous, edematous papules and vesicles following exposure to known allergen? The correct answer is B. The combination of acute monomorphic vesicles, punched-out erosions, and positive herpes simplex virus PCR is most consistent with the diagnosis of eczema herpeticum. This condition represents the triad of pre-existing dermatosis, characteristic clinical findings, and laboratory confirmation of herpes simplex virus infection. Early recognition of this pattern is crucial as it facilitates prompt initiation of antiviral therapy, which significantly impacts outcomes. Which condition is most commonly mistaken for eczema herpeticum in pediatric patients? Is it impetigo, contact dermatitis, scabies infestation, or molluscum contagiosum? The correct answer is A. Impetigo is most commonly mistaken for eczema herpeticum in pediatric patients. Both conditions can present with vesicles or pustules encrusting, especially in children with atopic dermatitis. However, impetigo typically lacks the high fever, significant systemic symptoms, and uniform punched-out appearance characteristic of eczema herpeticum. Impetigo lesions are also more commonly honey-colored and crusty, rather than umbilicated and erosive. A 4-year-old with atopic dermatitis presents with 2-day history of grouped vesicles, punched-out erosions, and fever. Herpes simplex virus PCR is positive. What is the first-line treatment? Is it topical corticosteroids alone, oral antibiotics, systemic antiviral therapy, or observation and supportive care? The correct answer is C. Systemic antiviral therapy is the first-line treatment for eczema herpeticum. Acyclovir is the most commonly used antiviral medication, typically administered intravenously in severe cases or orally in milder cases. Early initiation of antiviral therapy is crucial and has been shown to significantly reduce complications and hasten recovery. Treatment should begin empirically when eczema herpeticum is suspected without waiting for laboratory confirmation. Which antiviral regimen is most appropriate for a previously healthy 3-year-old with moderate eczema herpeticum who is stable with no systemic complications? Is it oral acyclovir 80 mg per kilogram per day divided 5 times daily for 7 to 10 days? Intravenous acyclovir for 14 days? Topical acyclovir 5% cream only? Or single dose of oral valacyclovir? The correct answer is A. Oral acyclovir at a dosage of 80 mg per kilogram per day divided into 5 doses daily for 7 to 10 days is the most appropriate regimen for a previously healthy child with moderate, uncomplicated eczema herpeticum. For children who are stable, able to take oral medications, and without evidence of systemic complications, oral therapy is generally effective. Intravenous acyclovir should be reserved for severe cases, very young infants, or patients with complications. Which factor is least likely to necessitate hospitalization for a child with eczema herpeticum? Is it age less than 1 year, extensive cutaneous involvement greater than 10% body surface area, history of well-controlled asthma, or signs of dehydration or sepsis? The correct answer is C. A history of well-controlled asthma alone is least likely to necessitate hospitalization for a child with eczema herpeticum. The major indications for hospitalization include young age, especially infants under 1 year, extensive cutaneous involvement exceeding 10% body surface area, and signs of systemic illness such as dehydration or sepsis. Other indications include immunocompromised status, ocular involvement, and failure of outpatient therapy. In addition to antiviral therapy, which adjunctive treatment is most appropriate for eczema herpeticum? Is it immediate resumption of high-potency topical steroids, pain management and barrier repair, prophylactic oral antibiotics for all patients, or systemic corticosteroids? The correct answer is B. Pain management and barrier repair are the most appropriate adjunctive treatments for eczema herpeticum. Lesions can be painful, so appropriate analgesia is important. Gentle skin care with mild cleansers and emollients helps restore the skin barrier. Topical steroids are typically temporarily discontinued during the acute phase and reintroduced gradually as the infection resolves. Antibiotics should only be used when there are signs of bacterial superinfection, not prophylactically. How should existing topical calcineurin inhibitor therapy, such as tacrolimus, be managed in a child diagnosed with eczema herpeticum? Should you continue at the same dosage throughout treatment? Temporarily discontinue until viral infection resolves? Increase frequency to control inflammation? Or switch to high-potency topical steroids immediately? The correct answer is B. Topical calcineurin inhibitors like tacrolimus and pimecrolimus should be temporarily discontinued until the viral infection resolves. These medications have immunomodulatory effects that could theoretically worsen the viral infection. Similarly, topical corticosteroids are typically paused during the acute phase of infection. After resolution of eczema herpeticum, these therapies can be gradually reintroduced, ideally with dermatology guidance to manage the underlying atopic dermatitis. A 6-year-old with eczema herpeticum has lesions around the right eye with eyelid swelling. What is the most concerning potential complication? Is it post-inflammatory hyperpigmentation, herpetic keratitis and vision loss, permanent eyelid scarring, or contact dermatitis from my medications? The correct answer is B. Herpetic keratitis and subsequent vision loss is the most concerning potential complication in this scenario. Herpes simplex virus infection of the cornea represents an ophthalmologic emergency requiring immediate consultation. If left untreated, it can lead to corneal scarring, perforation, and permanent visual impairment. Any child with eczema herpeticum involving the periorbital region should receive urgent ophthalmologic evaluation, regardless of whether they have obvious eye symptoms. Which systemic complication is most concerning and severe? Disseminated eczema herpeticum. Is it mild transient fever, herpes simplex virus encephalitis, seasonal allergies, or localized lymphadenopathy? The correct answer is B. Herpes simplex virus encephalitis is the most concerning systemic complication in severe disseminated eczema herpeticum. Though rare, it represents a life-threatening neurological emergency requiring immediate intervention. Warning signs include altered mental status, seizures, and focal neurological deficits. Other serious systemic complications can include viremia, bacteremia from superinfection, hepatitis, and multi-organ involvement, particularly in immunocompromised children. Which condition is associated with the highest risk for developing eczema herpeticum? Is it mild atopic dermatitis, severe, early-onset atopic dermatitis with high immunoglobulin E levels, psoriasis, or contact dermatitis? The correct answer is B. Severe, early-onset atopic dermatitis with high immunoglobulin E levels is associated with the highest risk for developing eczema herpeticum. The risk correlates strongly with the severity of atopic dermatitis and the degree of skin barrier dysfunction. Other risk factors include history of food allergies and mutations in the filaggrin gene, which is important for skin barrier function. These factors highlight the importance of aggressive management of underlying atopic dermatitis to prevent this complication. Which strategy is most effective in preventing recurrent eczema herpeticum in pediatric patients? Is it annual influenza vaccination, optimal control of underlying atopic dermatitis, daily sunscreen application, or prophylactic antibiotics? The correct answer is B. Optimal control of underlying atopic dermatitis is the most effective strategy in preventing recurrent eczema herpeticum. This includes consistent use of appropriate emollients, proper topical anti-inflammatory treatments, and trigger avoidance to maintain skin barrier integrity. Patients and families should be educated about avoiding contact with individuals who have active herpes simplex infections. For children with frequent recurrences, prophylactic antiviral therapy may be considered in consultation with dermatology. What is the most appropriate follow-up plan for a child who has recovered from eczema herpeticum? Is it no follow-up needed if lesions resolve, dermatology follow-up with optimized atopic dermatitis management plan, monthly viral cultures for 1 year, or indefinite prophylactic antivirals? The correct answer is B. Dermatology follow-up with an optimized atopic dermatitis management plan is the most appropriate follow-up for a child who has recovered from eczema herpeticum. This follow-up should focus on optimizing skincare regimens to maintain skin barrier function and prevent recurrence. The management plan should be individualized based on the child's atopic dermatitis severity and previous treatments. For children with recurrent episodes, prophylactic antiviral therapy might be considered. To summarize our discussion on eczema herpeticum in pediatrics, remember that this condition is a dermatologic emergency requiring prompt recognition and treatment. The classic presentation includes monomorphic vesicles evolving to punched-out erosions on a background of pre-existing dermatitis, typically with systemic symptoms. Early systemic antiviral therapy is essential, with special attention to potential ocular and systemic complications. Prevention focuses on optimal management of underlying atopic dermatitis. Thank you for following Pediatric Case Review. If you have questions, please leave them in the comments section below, and don't forget to subscribe for more informative presentations on pediatric conditions.